you that this is the cheap way to fortify your immunity. So people were drinking and licking 4 cups of ice cream. That wasn't enough. They even added 2 pieces of cakes to it. Anyway, you heard what Professor Solomon said. Genetically, we are prone to certain things as black people. And some of my very good friends who are here, some of our Caucasians and white friends, Karen is smiling at me, and she's wondering. Earlier on, I think I saw Chris. Chris was combining 2 wonderful things. I had to whisper to him, Chris, that goes with vegetable okra soup. And he smiled. So that we don't have a lot here. Neither do we come with 100 liver soup. On behalf of the organizers, we don't want to be responsible for anybody's coconut dance in the tummy. I want to say a big thank you so much to Concentric by Jinko. You have been a wonderful sponsor to make this event a very, very possible one. Sponsorship, as a matter of fact, is actually that strategic, insightful options that leaders in their industry actually take. And I can assure you that there's no better platform than to put your brand than the 9th African Conference on One Health and Biosecurity. And we're hoping perhaps in 2024, when it's going to be 10th edition, we're also going to have Concentric to be a part of that, as well as the other sponsors. It's going to be a bigger affair because 10 years is no joke. And then we're going to see how that becomes part of not just a major landmark, but a place where we are going to testify on the fact that so many of the things with regards to policies have actually been implemented. Lagos State obviously will be in the forefront, and of course in collaboration with Oyo State, as the case may be. And so, ladies and gentlemen, we want to say a big thank you one more time to all of our sponsors and supporters: Lagos State Ministry of Health, and Brook Heritage Holdings, Concentric by Jinko, Pennec Limited, at Biomi Farm Estate Affair. Please, they have displayed some wonderful sculptures and art edifices out there. I imagine some of us have seen some of those. We want to pick 1 or 2, and of course take a lot of pictures as you can and share. You can be amazed that these guys are very green friendly, and that is what it means for us to be able to embrace the new age that we're in, which is, of course, information technology as well as the green economy. 4 Point Real Estate Investment Limited, thank you. Peter and Jane Limited, and IRRSM, thank you so very much for your support in this regards. That is the International Institute of Risk and Safety Management, for being one of our sponsors to make this a reality, as a matter of fact. Please, I would like to announce one more time, let us be mindful of our personal items, our phones, our laptops, our chargers. These days, chargers are now expensive because of dollar. So you want to make sure this is not moving. Your handbag, you women, you can carry generator in that handbag, but just make sure you have it. After all, you guys are living longer than us. You don't know how much I'm piffing you people now. With this whole revelation that Professor Solomon revealed, I don't blame people for changing, you know what I mean. Anyway, this is not the, my dear, if you want to die, raise up your hand. Look at them. Okay. So somebody once said that, have you ever heard a woman writing will? What? Do women write will? Well, don't start the Beijing conference. That's first. We're here at One Health and Biosecurity Conference. But the beautiful thing is that in this age of diversity and the fact that we're bringing the best of the genders to bring on fore, tells us how much we can be able to tap into those human resources. Because at the end of the day, the man and the woman needs to work collaboratively for us to be able to create a world that is successful. And that is the way the creator have designed it, and we're very thankful for that. And so we will look at those collaborative sense and then explore that so that we can have a lot in terms of the positivism rather than the negative aspect of what we see, more of gender war, which I think is not necessary. Life is too sweet for wars. We should all be working together to make it even much more sweeter by creating solutions. And so, ladies and gentlemen, the next speaker will be speaking on the importance of a smart health information platform. I'm particularly interested in this presentation because I know it has to do with information. And this individual has over 13 years of experience in entrepreneurial development. He holds an MTech IT from Obafemi Awolowo University in Ile-Ife, and of course, graduated from the University of Ibadan. is continually expanding its expertise in information technology and serves as the co-founder and COO of A-Class Healthcare Limited, a health information systems company that has recently achieved successful capitalization in the Nigerian market. And we're looking forward to him to share with us some of the insight to see exactly how we can leverage on his experiences and, of course, on IT in order to drive the One Health agenda. Please put your hands together for Mr. Femi Olabigba. It looks like this clicker is giving us barrel tweet here. Please come and make sure it's functioning. Thank you very much. And thanks once again for giving us the opportunity to speak. I am to speak on the topic, the importance of smart health, but I have tweaked it a little to bring in the context of biosecurity, which is the conversation we have today. In contemporary health and social care, digital health technology has transformed the delivery and reception of care. We see digital technology bringing in superior value, especially as we aim to improve patient outcomes and also optimally utilize the scarce health resources. With capabilities in digital health technology such as software as a device, smart telemedicine, augmented reality, gamification, and so many other things that we know today. The literature has evidence to show us that these things are cost effective. They have economic benefits. They have cost savings. And they bring in even what we call process utility. They help improve the way we deliver the care. To harness all of this, it is important to have a digital landscape where all of these technologies are able to thrive. It's important to have a platform that aggregates all of this data into a single front. And this also becomes the landscape for the digital transformation that we so much desire in health and social care. So this is what brings about SHIP. Sorry, I'm supposed to be using this. So my topic really today is to speak on SHIP. What is SHIP? SHIP is State Health Information Platform. It is a novel idea of the Honorable Commissioner. Sometime immediately came into the administration, I think 2019, 2020, thereabouts. And this platform, I will try to define as a public health information infrastructure where digital products exchange data, supporting efficient, consistent, and future-ready health and social care delivery. So what we are building is a platform that holds all data when it comes to health. This platform is a PPP arrangement, so it means it's a public-private partnership. It includes us in the private sector and the government, the Ministry of Health, especially in that sense. It is a quality infrastructure investment, the way we envisioned it, because it builds on growing resilience and inclusive development.
As I mentioned, that is a PPP. It harnesses the powers of both the public and private sectors. We can, some of us will attest to the fact that it's stronger when you have a PPP that is mutually committed and responsible to an initiative like this. So SHIP comes with the goodwill of government, the equity contributed by government by giving access to the people, and the efficiencies that we all know exist in the private sector. All of these are coming to the play. As mentioned earlier, we, ECLAT, are a subsidiary of IntiSwitch. IntiSwitch is one of the biggest fintech in Africa. In fact, it was the biggest at the time. IntiSwitch today powers the financial transactions, most of the financial transactions that happen in Nigeria. All of the expertise that we've built over 20 years is coming to fall in building this, because the same kind of people that built the switch are going to build this ship. And in fact, perhaps even more knowledge has come into the organization and more experience will play out. SHIP would use the fast healthcare interoperability resources standard. This is an open source standard that is a newer version of HL7. For those of us that know HL7, HL7 is health level 7. These are protocols used to exchange health data anywhere in the world. So SHIP is going to ride on that. And in fact, for some of us that are familiar with NHS Spine, NHS Spine is the platform equivalent to this in the UK. They are in fact moving on to FHIR as well. So what we're saying essentially is that SHIP is riding on the latest technology as far as health data exchange is concerned. So why do we need SHIP? There's definitely data fragmentation all over the place. There are so many EMR software in the market. There's eClinic that we produce. There's Epic that is from America. There's so many of them. Now they have different structures. They keep different data. But as the commissioner of health wants to sit on the table and have a holistic view of things, how do we achieve that? SHIP to the answer. Brings all this fragmented data that sits in silos all over the place into a single front. I use the EMR as an example. SHIP is beyond that, and I'll elaborate as we get into it. There's always also some inefficiencies, some redundancies. So people doing things that a machine can do. A single process improvement can empower. SHIP would take out all of these inefficiencies, especially within our hospitals, within referral system, within prescription systems. Also, there is difficulty in regulating some of these hospitals and also in policy making. I'm not sure we can today say this is the total number of deaths that we have in Lagos State last week. I don't think we have such information. If we have it, it will take a lot of time to put it together, and we might not even capture certain data, especially the informal sector, the TBAs, the informal health carers that we have today. SHIP has actually been putting all of this together. So what happens on the SHIP? I would say SHIP has 3 layers. The first layer is the platform, the FHIR service that I mentioned earlier. On the second layer will be the services. So on top of SHIP, we would have things like electronic prescription system. So immediately we launch SHIP, you can expect that a patient can visit General Hospital at Ikeja, have a session with the doctor, and then perhaps that General Hospital doesn't have certain drugs the patient is to pick. The patient can leave the hospital without any paper, go to maybe a pharmacy at Agege and pick up their drugs, because the information has moved from that General Hospital and is available at Agege or whichever pharmacy location that the patient hopes to pick it from. Definitely, there will be levels of regulation to make sure all of Another service that would come out of this is what we call the summary care record. Okay, so once you walk out of the hospital, there are certain things that you've done. There were prescriptions, there was examination, there were documentation by the doctor, perhaps you even made some payments. All of this will be summarized into a single document that can be shared with the ship. So that way, irrespective of the EMR products that the hospital uses, all the data can still be collected in a single front. And the beautiful thing about this also is that the government is very conscious of the fact that we don't want to monopolize things. Let the market still play. So people will still have their EMRs. You know, so a hospital can decide to use whichever EMR. We're not going to make it compulsory for anybody to use a particular product. It will still be vendor neutral. Okay, and we would make sure the data is collected in a transparent and standard way. The third layer is where we then call the one we call the third-party application layer. At this layer, we would have innovators build a technology. Someone can say, well, I would like to have Uber ambulance, okay? And then he writes data on top of ship. He can pick the nearest hospitals that are ship compliant. He can be responsible for delivering reordered drugs because you already know the location of the pharmacy, you know the location of the patients. So we hope that a lot of intelligence and innovation will ride at that layer. I can't stand here and exhaust the possibilities there. In fact, many of the things that will evolve at that layer are new technologies that will come up, especially when we talk about all this AI and stuff that is the buzzword around the town now. Definitely to put all of this together, we're exploring artificial intelligence, we're exploring blockchain technology, we are exploring system integration, which is making different systems talk to each other. We will be working with big data analytics. There will be a lot of cyber security. We understand that this then poses the risk of exposing people's data. So there will be at the bottom of it a thick layer of security. We're already building a lot of resources around that. There will be cloud computing, there will be autonomous robotics, there will be all of these things. Internet of Things, definitely. We'd also ride that layer. Okay, I won't go more on this. A lot of the speakers have spoken about where this sits in the industrial revolution, revolution 4 and 5. SHIP actually exemplifies our play in the 4th and 5th industrial revolution. It's actually a very good example of how Nigeria is going to play in that space. So how does this get into biosecurity? Definitely, biosecurity plays a vital role in health protection. We need to, technology would help in managing disease prevention and control through quarantine, surveillance, vaccination, of course, public health, agricultural protection. I think we've learned a lot about that today, environmental protection, and very importantly, national and global health security. You know, I think the first speaker, Dr. Olabi, highlighted the threats that, you know, having a sample of Ebola can be on, the whole population. It can be very disastrous. Within this role, the role of digital health technology in all of this would be in disease prevention. I think one part of that would be the surveillance and early detection. We saw a lot of that play out in the beginning part of COVID, when we were really doing a lot of contact tracing, where we were able to pick people up. We'll be expanding that capability. Other roles of digital technology in biosecurity, bioinformatics and genomic surveillance, in which we make sure we're able to identify new and potential or dangerous strains. Okay, so what technologies would be at play in getting all of this to work? I mentioned the EMR earlier. EMR will be a very foundational system in putting all of this together. There will be a lot of telemedicine. Telemedicine, we can see the beauty of telemedicine today. You can sit at the comfort of your home and have a comprehensive consultation with your doctor, maybe some 30 kilometers away. In fact, we have even explored that further to take it to the rural environment. We have programs that run, and then consultants from somewhere in the Americas where attending to patients in rural Edo State. That's the beauty of technology. One can imagine that most people might never have had the opportunity to access such level of care, but technology then brings that forward. There will be a lot of video conferencing and lectures and training. Of course, SHIP can only be successful when the clinicians understand what we're doing, when the actors within the SHIP knows what the capabilities are. So there will be a lot of training. We'll be using SHIP to also train people to understand and use SHIP. We're going to bring on pharmacies. We're going to bring on labs, diagnostic centers, radiology centers. SHIP would have inventory management systems. The SHIP we're building, we hope that when we are live, the commissioner can sit on this table and with a few clicks know that we have used XYZ quantity of paracetamol in the past 1 week. And in the next 3 months, we will need XYZ quantity of another drug. Okay, because we know what we have used in the past. There is a way we can predict into the future what quantity we will need. All of these are the beauty of AI. And we're making sure we put in all the systems to allow us to do all of these things. Also, there will be a lot of information sharing. As we learn, our friends in the international community will get to enjoy our learnings so that we also can enjoy some of their learnings. There will be a lot of information sharing, especially in the public health space. There would be this lower bottom and this lower part of the slide is actually a lot. It's really around how we expect that SHIP would help the ideation, the processing, and then the output that comes from process utility. We can then really look at the operations within the hospital. We will, if needs be, remodel certain processes so that they are more efficient. Okay, so a patient doesn't have to go maybe 200 kilometers to make payment for something they will still come back here to enjoy. We can improve certain. So SHIP gives us an opportunity to have an in-depth view into the patient journey within the hospital so that the patient in the first instance feels the impact of that delivery of care. The relatives of the patient also, interestingly, when you are here, the relative that is taking care is also here because everybody is in and around. So the relatives do also see the impact of some of these things. Those are the kind of things we hope SHIP would achieve. Okay, so in all of this, it sounds very good, all will be beautiful, but we understand that SHIP is a very complex project and there will be a lot of challenges. In fact, in our experience today, we face a lot of pushback when we deploy EMR solutions. By the way, our EMR product is over 500 hospitals across Nigeria today. So we have very vast experience when it comes to delivering care, especially at the public layer. In fact, we have so many primary healthcare centers. Imagine going to a village and putting a computer there for a nurse or a community health officer that did not even know how to hold a mouse. That's where we start from. So we understand it being very, very challenging, but it's a journey, as many of the speakers that spoke earlier I said. We'll get onto the journey, and over time, we would be able to surround them. The way we see it is not just to be just about the healthcare we deliver today. It is also going to involve engaging the community of experts. We're going to get the bodies that we know today to get their buy-in, to get them see the vision that this is all about, and also get them to support us by making the members do what we are advocating for. Also, we will be advocating and influencing curriculum change. I mean, I'll give an example. In one of the PhDs that we have deployed at here now, the nurse, a community health officer now, should be perhaps in her 50s, about to retire. I think she was to retire about 2-3 years after that. And she tells us, you guys cannot force this thing on me. When I learned nursing, maybe you are not born at that time, I don't know. Okay? They didn't show me computer, so the governor should come here and tell me why I should use your computer. So we then have to find ways to cajole, to beg, to eat, go and help together, and find ways to come to the level, and then over time they get to appreciate it. In fact, some of them will tell us it's dead on arrival. Electronic stuffs cannot work. It can never work. Okay, why can't it work? It's because the guy he's scared of holding the mouse. That the subordinates would feel they don't appreciate technology. But you then take them out of that fear and onboard them. So we understand that there will be such challenges. There will be burnout, provider burnout. Now, doctors, these are other experiences we've seen in our ear now. They scribble, apologies to the doctors now. They scribble just a few things on the paper, and that's the documentation. Nothing useful for the future in whatever they've documented. Okay? It's bringing those inefficiencies out. So now they will be forced to document appropriately. Because really we need those documentation to drive the intelligence we need in the future. If you don't tell me that this patient has got headache and I'm diagnosing, or maybe he's got fever and I'm diagnosing malaria, I won't be able to use that combination in the future. So you have to provide me as much information as is required. Now, one other way I can wire this together is using the example of Professor Solomon earlier when he was explaining the kind of data they have in the blood bank. Okay, he was saying they would have maybe 800 breast cancer, 200 this, Now imagine that with sheep, you're not working with samples, you're working with the entire population. Because you have all of the data, you have all the breast cancer patients. So you can really explore the power of statistics. You can be more confident of the result of whatever extrapolations that you do. That is the power that sheep will bring in. So in summary, quality data is the floor for the digital paradigm. There will be a paradigm shift. People will be changing from paper to digital. Economies in the world are investing in the UK 2 billion over 2 years just building a digital platform. They've spent maybe 2 or 3 times that in the past 10 years, and they're still investing £2 billion. It's a lot of money. Okay, and they're still investing. Same in America's countries like India. So quality data is a new field, and we are planning to play very well in the fourth and fifth industrial revolution. Biosecurity has a place in technology, the environment, and in the national global security. SHIP is our future ready response to the digital economy challenge. What you hear in the Nigerian space is digital economy. I mean, it always comes to you when you look at the news nowadays. Okay, it's like our own response to that. Definitely, digital health technology is pivotal in biosecurity. We know it won't be easy, but we would embrace it with the braveness of Africa. PPP Center Spirit of Oyo State. I'm from Oyo State, and the excellence of Lagos. Thank you very much.
We just have one question, and we'll move into the next item. Let me just say that you're on your own with this Oyo and Lagos matter. You didn't hear it from me.
Okay, thank you. That was really good. I have one. I'm going to try and fix it into one question. My name is Dr. Simi. You talked a lot about hospitals and the EMRs. Which PHCs have you launched the EMRs in? Because I visited one last week as a patient, and it was paper from top to bottom. So it'd be nice to know whether you are starting from bottom up and going through all the PHCs as best as we can, even if it's not the full EMR, to help with referral pathways, because you mentioned that. And I know about the opt-out for patients who don't want their data shared. Is there any consent that we're going to give patients so that not everybody has that? And then also the pharmacies as well, because most of the prescriptions are generated from primary healthcare. They should be from primary healthcare centers, but it sounds like it's more of a secondary care focus, and it's that general hospitals that your EMR is already in.
All right, great question. Personally, if you are the doctor, I won't give you a consent, but she I will give. Thank you very much for that beautiful question.
You would give me the opportunity to maybe qualify SHIP a bit more. SHIP is not EMR. Okay, I mentioned EMR because it's an input into SHIP. SHIP is a platform to exchange health data. And that's the way, if there's anything you take out of all I've said, have it in mind that SHIP is a health information platform. The PHCs I mentioned are not in Lagos. They are in Oyo, Edo, Delta. Right? And yes, this will be a top-bottom approach. We're going to start with the tertiary and secondary care, and then we'll cascade down to the why? When? It's a journey, I can't say. No, SHIP is already starting, we're building. EMR is already running in a number of hospitals. Hopefully maybe next year, thereabout, but it's not happening immediately. We're going to pilot this. That's why we want a number of hospitals that already use EMR will be the ones who would onboard first onto SHIP, and then begin to expand as we get along. Because we'll learn it, and then we'll pick up learning. So the other question you asked was on the privacy. So definitely privacy is a big thing. Your data will only be shared with a third party if you give the consent that it be shared. However, second party is the Ministry of Health. They will have your data. The government owns your data. They will have your data. We that we are building with, we will not have access to the data. Okay, but the government will have access to the data. Okay, but if you now want to share that data with a third party, for us, who will be the third party? Okay, a pharmacy will be a third party. Another hospital will be a third party. You can then give a consent to get your information shared.
Thank you. Thank you very much. Whether you like it or not, doctor, the government will have the data. And there is nothing about it. So that is the power. So, and of course, I think it's the collaborative efforts in terms of the PPP model. And when we keep talking about data, it's obviously because of the negative, effects that people oftentimes who are not genuine actually engaging with. The data is a new oil, and what we can do with that data is one of the things that we need to be able to explore. We're looking, there was a presentation that was focused on effective data and information sharing system to enhance early warning and disease surveillance in Lagos State for sure. The very sure Lagos State is going to come forward to adopt a lot of this. The next speaker, ladies and gentlemen, has a progressive career path in the healthcare sector with multiple areas of focus on healthcare financing, hospital management, information systems, healthcare quality, human resource management, and business development. It currently serves as the technical assistant to the Honorable Commissioner for Health and Health Economics at the Lagos State Ministry of Health. Is a member of the Project Management Committee on the Medical, Diagnostic and Services Provision MDSP scheme, a program focused on facilitating private investment in the delivery of public health services. As a matter of fact, he's a man who I hold in very high regard, and he's going to be speaking on the topic public health care financing in Nigeria, which way forward. Please put your hands together for Dr. Olamide Ogulaja as he comes up to make his presentation.
Hi. Good afternoon, everyone. It's great to be here. Usually the disincentive for being one of the last people to present is that the hall is almost empty. But the good thing is that the people that are still here are the people that are the serious ones. So please, everybody, give yourselves a round of applause for still being here at this time. I'm very, very happy and excited to be speaking with you again today. And I'm going to be talking about public healthcare financing, which way forward. And that's my very first slide, which is that we have not yet learned our lessons. We've not yet learned our lessons because if today we were to have another pandemic, we will still be caught with our pants down. How many people agree with me? If I agree with me, raise up your hand. During the COVID pandemic, there was a lot of financing that went into healthcare. A lot. And a lot of structures were put into place. A few months down the line, the only thing that reminds us of COVID is the genetic mutations that are happening to our bodies. We don't see anything else. Everything is gone. You walk into a building like this, no hand sanitizers. You walk into government hospitals, IPC controls have disappeared. You walk into isolation centers, they've all been deserted. Governments no longer want to hear about COVID. And they feel, in fact, that they've spent enough money on healthcare in the last 2 years than they've ever done, so don't bring anything health to me. And that is why I said we have not yet learned our lessons. But there's a reason why that we've still not learned our lessons. Because we are very used to the word free. We're also very used to the word borrowing. In fact, in replacement of free, I wanted to put begging there, but I said begging is too strong. But we are very used to begging, and we are very used to the word free. However, no nation can base the financing of its growth and development solely on the goodwill of other nations. None. And free and borrowing are not a sustainable resource mobilization strategy. A lot of times we rely on donor funding, and you hear things like partnering. We need to partner with, and we need to rely on, and we need to speak to the AMDB, and we need to speak to the World Bank. But we never look into our own pockets to see what we can put forward towards the very plague that bothers us. And yet, COVID was very, very clear in not only having impact on our health, but also the economic status that we hold during that period. A lot of people lost their jobs during COVID, a lot of people died, and a lot of people have still not recovered from that very concept, because what COVID did was it taught companies to, tone down their expenses and reduce the need to hire as many people as possible. And so you still have a lot of people that are unemployed till today. Unemployment rates are still they are the highest they've ever been in the country. as high as 38 to 40%. So imagine a population of 218 million people with an unemployment rate of about 40%. You know, you would never call me on a stage and I will not talk about the economics of Nigeria, because that's what I do. And besides, I never look at healthcare in isolation. I always look at it within an ecosystem. And so if you look at some certain indicators that measures the health of our economy, there's one called the debt servicing to revenue ratio. So basically, debt servicing to revenue ratio is an indicator that measures the amount of money we make versus the amount of monies we use to pay the interest on our debt. And basically, as of today, it is about 73.5%. So imagine that a country makes, what, 10 naira. And out of that 10 naira, before it decides to even spend on its budget statutorily, it has to pay out 7.5 naira. So what is left? About 2.5 naira. And that 2.5 naira will be spent on all sectors, including money-making sectors. So sometimes I wonder where health would be when they are making that division to say, how much are we going to give to health when we need to build roads, when we need to build, we need to have capital investments, we need to do all of that. And of course, a lot of times the deficit that needs to come into play comes from borrowing, which further worsens our debt servicing to revenue ratio. And so the debt management officer has said if we are not careful, by the end of 2023, we might actually hit 100%. We've been very close. In 2020, it was 97. In 2021, it was 82. In 2022, it was 96. Now, I'm telling you these things because I'm getting somewhere, so you need to really try and follow me, okay? I hope I'm not too boring. Good. Now, you look at Nigeria's THE to GDP, which is total healthcare expenditure. So, over the last 4 to 7 years, it has wavered between 3.8 to 3.4%. So, Nigeria as a country, both in the private and public sector, is not spending the recommended of about 10%. If you also look at our budgetary allocation, what the government is allocating to healthcare over the last 10 years, it has wavered between 3 to 5%. Have we learned our lessons? Our debt to GDP ratio, when big boys, the IMF, the World Bank, they say when you get to a debt to GDP ratio of 60%, you are in trouble, right? But if you are still below 60%, you're fine. Nigeria's debt to GDP ratio has risen from 27.69 in 2018 to 2023, 38.79, which basically means that our debt profile is constantly increasing. And there's a reason why I'm telling you this, because you'll be wondering, what has all of this got to do with health and biosecurity and public healthcare financing? So I like little entries. I've given you the entry of the economy of Nigeria. So I'll give you the landscape and the overview of the public healthcare issues that we have. So unfortunately, the only public healthcare issue we have is not just biosecurity. We have a plethora of them. We have a high percentage of unregulated practitioners. We have heavy outbound medical tourism. We have retrofitted buildings that don't literally make sense. I mean, you go to a primary healthcare center and it's a two-bed. And a lot of people want to immortalize their name. So what they do is that they contribute. just Lagos, it's all over. I mean, I've also been to facilities in some other states, Delta State. I walked into a building in Delta State, and somebody had donated a PHC, was fully fitted, 4 ambulances, 2 generators, perfect. The day it was donated, it was locked up. The next time that padlock was opened was when we went there. It was 4 years later. Everything had degraded. What was the reason why? Because the government didn't tell you they needed a PHC, but you decided to give them a PHC. And running a PHC is bigger than just building it. You need to actually strengthen the PHC by putting staffs there and putting monies for consumables. But if that's not in the budget, then government can't do it. We have poor maternal mortality outcomes. Believe it or not, Nigeria has the highest maternal mortality in the world. Now, don't get me wrong. People will come up and say, Dr. Kulaja, that's a blunder. Because Chad has the highest maternal mortality rate. But in terms of absolute figures, Nigeria does. Is that not a shame? Till today, despite all the millions of dollars that have been spent on healthcare, we are constantly losing patient trust. We have weak enforcement of policy, poor governance systems, ill-equipped facilities, and of course, we are constantly plagued by a brain drain. So you look at what is the Nigerian government's ability to currently fund our healthcare system? To be honest, it doesn't exist. Look at the economy of Nigeria and begin to think about how Nigeria can actually begin to allocate resources to fund a healthcare system. Does it exist? It doesn't. So what is the way forward? Politically, Nigeria promises a socialist healthcare system even when the country cannot afford to feed itself. Nigeria believes in the word free. So when presidents and governors are making political statements, they say, oh, free. But you go to a public facility and first of all, it's not free, but second of all, you do not even get a holistic treatment because a lot of times things are not even available. Over 80% of our revenue is spent on debt servicing. Nigerians, as a people, do not even believe in putting money aside for healthcare. And so at the point of care, healthcare is a lot more expensive if it is not pre-pooled. Technology, I mean, I'm happy to hear people like Eclat talking about SHIP, but unfortunately, our approach to health systems do not promote innovation and strategy because a lot of times people assume that when we talk about technology, we're just talking about information technology. But technology is simply what? Science making life easier. So because we are used to a particular way of doing things, the way that we apply our technology usually does not promote innovation and strategy. And environmental, our way of life is generally unhealthy, leading to a rise in communicable and non-communicable diseases. And of course, there is a confusion to the ownership of the tiers of healthcare delivery, federal, state, and local government, because constantly you are finding the 3 tiers fighting over the same children. But I say something all the time. I say if a child has 3 fathers, then that child is an orphan. Because each father will continue to push you to the next father. Because resources are scarce. Daddy, I don't have a pair of shoes. Go and meet your other father. Go and meet your other father. By the time he comes back, the boy is tired of asking for shoes. He's just walking to school. Right? Meanwhile, he has 3 fathers. So now that you have some overview of our economic landscape and the doom that is our healthcare system, let me start giving you some good news, sort of how we can sort this out. And one of the best ways that have been proposed is what has been defined as health financing. Now, a lot of times when people talk about health financing, people they think that health financing is about financing health. I don't know if that makes sense. People think about money when you think about health financing, but unfortunately, I want to break that myth today because health financing is not about money. It's not. Health financing is the interplay between the supply side and the demand side. Supply and demand. And the denominator between supply and demand is what? Quantity. So demand is desired quantity, supply is available quantity. So how do you match what people actually need versus what is available and how they can play together? And you do that through supply side financing and demand side financing, right? And it has to be, for health financing to be successful, it has to be a continuous linked loop, which means that for you to have demand, there must be supply side financing. Do you understand? Which means that for the desired quantity to be achieved, you have to provide some form of financing to the supply side. Because if somebody wants to buy Panadol, if somebody is sick and needs Panadol, he goes to a facility, and that facility has not been properly financed to be able to stock Panadol, then when he gets there, he doesn't get Panadol. On the other side, there has to be demand-side financing for the supply to be available, which means that there has to be some form of monies that follow the request for Panadol for you to have monies to make the supply available. If that's too confusing, I'll move to the next slide. But basically, what I'm trying to say is that health financing has three main tenets, and I'll really talk about them very quickly now, which basically is revenue raising, risk pooling, and purchasing of services. And what are the different ways of raising revenue? Sources of funds, including government budgets, compulsory or voluntary prepaid insurance schemes, direct out-of-pocket payments by users, and external aid. These are funded through domestic resource mobilization for healthcare. A lot of times when we talk about revenue raising, the only thing that people think about is health insurance. But health financing is not health insurance alone. Health insurance is actually a component of health financing and the revenue raising part of health financing. Now, when you then raise that revenue, it's important to pool the funds. So all the funds you've gotten from government, from health insurance, from everywhere else cannot be treated in isolation. You have to pool all that money into a pot and then use that money to pay for services in both private and public facilities. And that deals with the last part that talks about the payment or allocation of resources to health service providers. And then we have the gamut of what we call health financing. So, since we know this about health financing, what are the problems with the Nigerian healthcare system and why do we have these challenges? First of all, we have narrow sources of funding. Budgetary allocations are not enough. If they are not easily drawn down. So you have a situation, so there's a difference between budget allocation and budget performance. So it's one thing to even allocate, it's not even enough, because most of the time governments allocate 4%. Abuja declaration says they should allocate how many percentage? Do you know? 15%. So there's first of all a disparity. And then from the 4%, usually the drawdown, which is the actual ability to access funds, is usually about 2%. Right? Again, our health insurance schemes are not viable. And it seems very funny that I would say something like that, but I will explain as I go on later. Of course, majority of the Nigerian population are poor, so they're unable to actually pay for healthcare, so they need some form of subsidy. And another major problem we have is that we have a large informal sector. So if you have a large informal sector, it does two things. It means that one, government is unable to tax its informal sector, so the ability to raise funding to do social amenities is weak. In Lagos State, the tax to GDP ratio is about 2 to 3%. Can you believe that? So if the tax GDP ratio in Lagos State is 2 to 3%, then what is the tax GDP ratio of Nigeria? Does anybody know? About 3 to 4%. And we have been told that for any country to have any form of capital development or economic development, you should have a minimum of 12.75%. Countries like the UK that we compare ourselves to all the time, and America, have between 33 to 40% tax GDP ratios. Are you beginning to see the problem? Because a lot of times, it's very easy for us to think about the innovations and the things, but if we do not have the money to push these things, then we are wasting our time. I mean, one of the things that I really enjoyed about some of the previous presentations, like there was someone here, and I would call him an esoteric professor, and he brought up a slide that was very, very technical. But he said, in this slide, I'm going to only refer to one thing, and that thing is sustainability. I almost stood up to give him a round of applause. A lot of people didn't really get what he was saying, but what he was saying is that if you do not create sustainable systems that can constantly pay for these things, then we are wasting our time. And it is the reality. So, what do the textbooks teach us? It teaches us that domestic resource mobilization for healthcare, there are 5 main types. You have the taxation, which everybody knows. Government taxes people, and then he uses that money to pay for healthcare and other social amenities. Countries like the UK, what they've done is they've taxed people, and then they've taken part of that tax to actually pay for free healthcare. Countries like France, what they do is that they tax specifically for healthcare, and they contribute into what they call a social health insurance scheme. And you'll be shocked that in a country like France, they tax between 20 to 37% of their income for health alone. Can you believe that? That is how seriously they take healthcare. Sin taxes. Sin taxes are also ways of raising monies for healthcare, where you tax what we call luxury items, or things that make you prone to diseases like orange juice, packet juice, Coke, cigarettes. But unfortunately, we've not only been able to tax those things effectively in Nigeria, we've also not been able to effectively target them towards the healthcare system. Corporate tax, lottery tax, these are ways that have not yet been harnessed for healthcare. And to a certain extent, I don't blame governments really, because even the money that they are collecting is not enough. Health is not their problem. It's not. They need to build bridges. Do you understand that? They need to build roads. So you're telling them to do what? Things that they cannot see. How are they going to use it in their next election? To say what? I provided health insurance for X number of people. Yay! Everybody give me a round of applause. Who's going to give me a round of applause? But if you say, oh yeah, look at this Yaba bridge that I just did. Yay! Yeah. Next election I'm in. Right? So how do we begin to, first of all, think of ways of assisting governments to improve their taxes, which a lot of us as doctors are not even thinking about. You see, doctors and healthcare professionals, because we are very esoteric and we think a lot, we only think about taking to do the work. But the question is, how can we as doctors also begin to contribute to actually building the tax base of government? And that's a question we really need to start thinking, because the only way you can actually take is when you give. Think about it. You have 2 kids. One likes ice cream. One likes books. And 2 of them come in front of you and say, Daddy, give me money. Who are you going to give money to? The ice cream boy or the one that likes books? The one that likes books, because you know that he's going to read those books and one day he's going to take care of you in your old age. This one is just going to lick ice cream till he dies, right? Diabetes is in the future. It's going to cost you more money, right? So again, you need to begin to think about how do you assist governments to raise revenue, that government will then be engendered or endeared enough to allocate some of it for healthcare. Healthcare spending efficiency, it's a big problem. Big problem. I'm not really going to go into that because we all know the story of efficiency and effectiveness in our healthcare spending, right? Social health insurance. I'll talk about social health insurance shortly, but that's another way of raising revenue for healthcare. And donor funding, which is our favorite, no donor fund that does not have a name to it. So if I'm giving you money as a donor, there's actually something I need from you, right? And there's something I need you to use the money to do. So except you're willing to do that for the rest of your life, or whatever value you're going to be given is going to encourage the donor to continue to give you funding, which I don't think is possible. You need to begin to think about alternative ways to break that bond and generate enough money to actually deliver yourself and create a sustainable system. Private sector investment, we'll talk about that. But for me, private sector investment is the future of healthcare public financing. What is the opportunity for a private sector? So one thing that when we think about the private sector, we think about the private sector as that body that can only give us financing. But I guarantee you that there's also a lot of innovation and strategy that comes out of the private sector. Things that the private sector has done constantly over the years that has allowed them to be able to become successful. How can we leverage on those things to actually improve our own healthcare systems, apart from just the money? One, there needs to be built a trust between the private sector and public. A lot of private sector people do not trust the public. They feel if they deliver service, if they partner with government, they're never going to get their money back. But we're able to change that with COVID. And very quickly, from actually pleading with some private sector people to partner with us for testing at the beginning, it rose very quickly to us having about 36 private labs. In fact, it got to a point we had to stop people from coming into the private sector lab consortium. It was that successful. And that was because we're able to build a trust between government and private sector for the first time in a very long time. And those guys that we worked with, if we call them again and say, come, let's do something, they will quickly come because they saw that partnership working. Policies are a lot of the times conflicting with government commitments. So again, you find a government or a state saying that it wants to do a social health insurance, but at the same time, it is offering free healthcare. So it's conflicting. People are confused. And then you have BHCPF that is being funded by the federal government that again offers free healthcare down the line and conflicts with the social healthcare system, insurance system at the state level. Conflicting roles. We need to begin to streamline what our policies are so that people can have a clear direction of where they want to come in. And of course, government needs to increase funding and really leverage on private-public partnerships and of course, private sector financing. The opportunity for health insurance. So I'm not sure a lot of people know this, but sometime last year, was it last year or 2 years ago? Actually, it's 2 years ago now. It was last year. Sometime last year, President Buhari signed the National Health Insurance Authority Act. And what that act put into play is that one, it established state health insurance schemes, and two, it made sure that everybody got enrolled into a state health insurance scheme, which means everybody in this room as of today should have a Lagos State Health Insurance card. Unfortunately, there's a difference between policy and implementation, and that's a huge gap. However, if that is done, you begin to have state health insurance agencies that enjoy economies of scale, large scale. You begin to have the mandatory nature, improving the pool of funds. The agency will be able to lower the cost as well. They will perform admin functions directly, but of course there will also be economies of scale, and it empowers state health insurance schemes to have its own agency. So what are the implications? Increasing funding to pay for healthcare, incentivizes the private sector to invest in the supply side, increase employment and job opportunities while increasing internally generated revenue, and also it fosters competition between public and private health facilities, thereby increasing quality, promoting innovation, whilst raising the cost of delivering care. However, So I have said there are two main ways of us trying to actually solve our public healthcare financing. One, private sector partnerships. Two, health insurance. But there's a problem with our social health insurance schemes because studies have shown us that if any social health insurance scheme is to be successful, it has to have these three things. One, there must be government subsidies. A government that is not making enough money, how can it subsidize? Big problem. Two, you must have employee-employer deductions. In a geography that you have 80% of people in the informal sector, how are you going to have that? And three, there must be quality healthcare facilities. Have you been to our primary healthcare facilities recently? So, how are we now going to have a social health insurance scheme that functions properly? How soon be done? How soon be done? Right? Again, qualities of a social health insurance scheme, it must be equitable, it must be progressive, which means that people must pay according to what they earn, right? There must be solidarity, we must coalesce risk pools, and we must leverage on efficiency gains. So the way to get the best out of our health insurance system is that we must use our demand side to fund our supply side, period. If we are able to get the mandatory nature of health insurance in play, that money must follow care to the supply side. And that supply side will then use that money based on that little bill that I showed you at the beginning to improve its facilities so that it can encourage more people to get on board and bring their monies in again. So we must be able to create what we call a virtuous cycle. So it must be closed. And we must then be able to regulate that virtuous cycle to make sure that people that actually pay for health insurance are able to access the care that they need. Again, we must leverage on partnerships. For the partnerships I'm talking about now, like actually the health maintenance organization, they've been around for a while, they've learned the ropes, so we must not throw them out and say because the government has now approved us to do our own health insurance schemes, we need to get the HMOs out. No, they have done it for a while. There's a need for us to partner with them, see how they've done things previously, and learn from them. Again, it's important that there is a progressive nature. The rich must pay more so that the poor can access the same quality of healthcare service. Believe it or not, a lot of people don't think that. A lot of people think that because I'm rich, then I should have the best healthcare, and everybody else that is poor can have poor healthcare. And I've been in rooms when people talk about the development of PHCs, and I have one of my ones here who is the permanent secretary of one of the districts in the PHC system, where people have said, let us upgrade that PHC so that our people, the poor people, can access care. No. Let us build that PHC system so that all of us can access care in that PHC system. That is the essence of an egalitarian healthcare system. I should be able to sit in the same PHC that a poor person sits in and access the same level of care, because one of the things that is ubiquitous with us is human rights. But let's not go deep into that, because that's another big conversation, right? I'm not even going to take you into this, right? Because this is a bit complicated, but it's an economic term that I use to explain the relationship between the private sector, the public sector, competition, and how you can actually get the best, and it will actually lower the cost of healthcare at the end of the day. So one of the things that the NHIA has done recently is that it has released a guideline. And in that guideline, what the NHIA has proposed is that 15% of a person's salary must be contributed to a state health insurance scheme. 10% by the employer, this day and age, where we have 1,000 naira to $1, you want to further tell them that they must pay a percentage. It's a big problem. There's something we must try to avoid, which is the deformalization of the formal sector. Because that's one of the things that the private sector knows how to do very well. When you push it to a corner, it will begin to think of ways to get out of that corner. And one of the ways it will do that is firing its full-time employees and hiring everybody on a contract basis. And so you will not only get the money for health insurance, governments will lose IGR because then you cannot trace anybody anymore. Everybody has gone back into the informal sector. So when we make rules and suggestions as government, we must begin to think about the economic implications of those things that we are doing. And that is one of the biggest problems we have in Nigeria, because we do not have economists sitting in the room when policymakers are making decisions. One of the things that I basically think that needs to happen is, you see, the NHIA has created a mandatory nature for health insurance in Nigeria. But how are you going to enforce it? How are you going to enforce the mandatory nature of the health insurance scheme in a population where 80% of people are in the informal sector? You don't even know how much they earn. You don't know where they are. You don't know where they keep their money. So I'm sort of proposing that we must begin to tie the mandatory nature of health insurance to social amenities. So you cannot get on a bus if you don't have health insurance. You cannot take a taxi. You cannot order an Uber. You cannot access healthcare. You cannot even send your kids to school. It becomes a prerequisite. And once you're able to do that, then everybody begins to pull money into a pool. And then we can use that money to fund our public healthcare system. We cannot afford to simply build a healthcare system for the poor. This approach is unsustainable. We must work together, building a sustainable healthcare system for all and facilitating access to the poor and underserved. Thank you very much.
Thank you very much, Dr. Okulaja, for that presentation. Very insightful, I must say. It's important because finance is that oil that greases the engine of economy. How we're going to obviously get it right in the health sector is a major challenge. Obviously, a third world country, the way I see it. Sometimes when I see a lot of these statistics, I just close my eyes and go back to sleep. Yeah, because I don't know where we're going to start from. So, Keg is around? Alright. So, ladies and gentlemen, without taking our time, we'll have our next presentation before we have our two last abstract presentations, which should not take more than about 10-15 minutes, and then we'll call it a day. Like I promised, we're going to have this moment wrapped up. My next speaker is Dr. Keg Douglas. He's a professional senior scientist recognized both regionally and internationally for impact scientific research in the fields of microbiology, infectious diseases, biosecurity, and virology, and zoonosis. As a matter of fact, it was here last year in person. However, this year is going to be joining us virtually. And he's obviously operating at from Barbados and of course the Caribbean. And how much of that we want to see is actually expressed here today at this 2023 edition of the conference. And it's speaking on development of a climate-resilient artificial intelligence trades platform for sustainability. And he's going to be speaking for the next 15 minutes, more or less, or 20 as the case may be. Tony, are we ready with him? And after that, we will have the last abstract presentations that are going to be going on here today. I understand Dr. Ian Peter, and as well as Valeria Mathieu will do that. Obviously, we call it a day. Can you hear me? Can you say something if you can hear me? Hello?
I'm very sure that tomorrow we won't have this experience, but we still have two more presentations as the case may be. Keg, Dr. Keg Douglas is up online. Can you hear me, Keg? Can you say something, Keg? If not, we might just have to find a way of having them present it tomorrow. That might be that they will start up the event, but it depends on their own schedule as well. So let's just give the technical guys some few moments to see if we can have any of the other two. All right. Kashmir has done.
Hello?
Yes, we can hear you, Kirk.
Can you hear me good?
Yes. Okay, try sharing your slide.
Yes, let me see if I can share my screen.
So we'll be glad if you can wrap this up within 10 minutes. That would be great.
10 minutes.
Yeah,
I can certainly try.
just do your best. That's why you should have been here in person.
Yes, I try to. Trust me.
Don't tell me they denied you visa. Okay. All right, you can go ahead. Pardon me, I was just being naughty.
Yes, I know, that's okay. We got a full screen mode. Can everyone see?
Yes, we can see you.
Brilliant. Thank you very much. Good afternoon to all of you, and thanks once again to the GET Consortium for inviting me to be a part of this magnificent Biosecurity and One Health conference in Lagos, Nigeria. Greetings from us here in Barbados. And today I just want to briefly introduce you to a new project that we are very excited about. It's called the Climate Resilient Artificial Intelligence Trade Platform of Data. And this is the Center for Security Study. This is our concept of biosecurity at the moment. Very multidisciplinary, and we're trying to integrate several different aspects in what we consider the One Life approach, which is more expanded than the One Health. And it involves the three risk factors: infrastructure, environment, and human. This is some of the research that we have already started. And in order to understand risk, you have to be able to measure risk to be effectively manage it. It's like your blood pressure. If you don't measure your blood pressure, you're very, very, very challenged to have effective management of your blood pressure. So what are we seeking to do with this CREATE system is to essentially look at the convergence of climate, of trade, of tourism, of climate change, and then look at the cascading impacts of air pollution, pandemics, and infectious disease. And these are the SDGs that this actually looks at. Now, these are the climate. These are the climate risks. Can you hear me?
Recording in progress.
Oh, sorry, yes. So these are the list of the climate risks, climate impacts, disasters, epidemics, global economic shocks, and adulterated products. These are things that face the Caribbean, and I'm sure this is not only Caribbean, but several other countries, which have secondary risks such as supply chain disruptions, economic inflation, and also the reduced global travel. And this is a snapshot of Barbados. Sorry, here in the Caribbean, we import about 90% of our food. Barbados about $1.6 billion in imports. And this has obviously a risk because if they're adulterated products that are manufactured elsewhere, then we have to have systems that are able to understand what are the impacts of these contaminated products on our populations. And we have to have a rapid track and trace system. But this is really challenge because we have limited data. And so we are trying to not create new data, but actually de-silo data from within the trade sector, within customs, and also within the health sector to be able to track and trace, for instance, their drugs that are recalled. Then we have to be able to rapidly track and trace them to the persons who they've been administered to from pharmacies and be able to recall them in an efficient manner. Now, climate change is another interesting risk that is, it's been a challenge for all nations, actually. And these are systemic risks that actually impact on trade as well. And so, how can we anticipate when these impacts occur before they do happen so that businesses can be more agile and be able to pivot? Right now in the Caribbean, we're impacted because of the drought that's currently undergoing in the Panama Canal. This is obviously increasing the rate of the transit time of cargo ships from either side of the Pacific Ocean and the Atlantic Ocean. And this is causing increased costs for goods coming into the Caribbean. And I just showed 90% of the goods we consume are actually sourced elsewhere. And so we want to see how data and artificial intelligence and machine learning can be able to understand both, not only on the supply end, but also on the demand end, so that you can pair both together and help not only public health, but also businesses to understand what the impacts are in the future. Stopped. Sorry, this is it's going so well now it's stopped altogether. Right, so these are the objectives here to be able to design this data ecosystem. Sure, what's happening.
Okay.
Pixels. Am I still with you?
Yes, you are.
Hello?
Hi, Keg. We're here with you.
Okay. Right, so I'll soon wrap up. It shouldn't take too much longer.
Thank you.
My apologies for these technical difficulties.
No, it's all right. We're experiencing it here in Africa too.
What we're seeking to do is have these inputs of the financial partnerships, the financial resources, people and experience, take these data sets, conduct a relative analysis to then essentially create this new data system. Because if you can anticipate when these climate risks occur, then you could help businesses be able to be more agile. And this is essentially how it would look and how it would work. And based on the air travel, the sea and air cargo data, if you can de-silo that data by the specific products. And how you would do that is using the barcodes, because each product should have a barcode, and be able to trace that movement of the product from the time it leaves the supplier, then when it enters the country, and then when it's distributed throughout the country. Then you're able to have an active system that is based on each of those products. And this is what it's looked like. These are some of the partners, CARICOM Impacts and CARFA, both of these. This is the regional security, and this is the regional public health. And what we will look to have as inputs would be air and marine trade data, climate data, also the incoming tourism tourist volume data, then any existing endemic and also chronic disease data and waste management. This would then hopefully, because we are at the cusp of actually rolling out this program with a regional company that has a regional footprint, and this is a fast-moving consumer goods company. We recently signed the NDA with them, so we're now going into the actual implementation stage very shortly. And what we want to do to collect data from them regarding the trade volumes that they have, because the outputs from this system will enable us to, one, be able to have supply chain disruption forecasts, and also based on the incoming volume of goods and also the demand within the country, you can actually help the local farmers to be able to plan their production based on what the local demand is coming. What you would also be able to do is to characterize and also generate waste volume forecasts, because based on what products come into your country, then once they're consumed, they're then converted into waste, and therefore you can have an estimation based on your trade volume of what your waste would look like within your country, and then also to be able to help cure medical, health, dental supplies, and also have a track and trace system, food and biosecurity system, food safety and biosecurity system on both local and also imported goods. And this would also have spin-off benefits in terms of savings, affordable food, bioenergy and recycling futures, healthy population, and a safe food supply. This would be the target, these different target audiences, sorry. This will show you for the fast-moving consumer goods, and this is one way we're going to try to see if we can generate revenue by being able to perform analyses for these enterprises to help them to be more agile and also more competitive within their different markets. And as it relates to sustainability, being able to anticipate what volumes of particular goods you're having helps you to plan your solid waste management. Because once you pair what you import with what you're manufacturing, what you're producing during your agricultural production, then you have a broader view of what your waste situation looks like. And that helps you to plan in terms of your solid waste management, also your bio-waste energy futures in terms of what volumes of bioenergy you can produce from your bio-waste, and then also your recycling futures, what volume of recyclable materials you have, and then be able to plan accordingly. And that's really the end of the presentation. The only thing I would have to add is that we are about to launch our biosecurity and biorisk postgraduate programs, and this will start off with our research degrees in January and February of next year. And this is a really, advanced program that we're seeking to develop and launch, and this will help people to actually understand the interconnectivity of issues, because what is lacking at the moment is the siloed nature that we're operating in, and in real life, this isn't how these issues evolve. They evolve in a very multidisciplinary and a very interconnected way. So we are going to train people how to analyze these different opportunities, these different risks, to be able to solve these complex risk problems and devise comprehensive and integrated biorisk management solutions. And this is what the program will look like. We're going to have 7 different focal areas, and persons can choose their particular stream of interest. And these are the prices and also the different program length. And so we encourage those of you to spread the good word, and we look forward to a very exciting 2024. And here's my contact information, and a blessed and wonderful evening to all of you there in Lagos. Thank you very much.
Thank you very much, Dr. Douglas, to you as well. We're glad that you were able to join us virtually. Hopefully in 2024, we're going to have a much more wonderful anniversary, which is going to be 10th year, and we'll see whether you can join us. Apparently, we don't have any questions, and we'll be reaching out to you. Thank you very much. Our next speaker will be Dr. Ian Peter. We will speak for the next 10 minutes. And then finally, to close up for today, we have Deborah Anyado, who is here in person. She is going to be concluding today's presentation on behalf of all of our speakers. Is this Dr. Ian Peter? Okay.
Yes,
You almost looked like somebody who was wearing a scarf, but when you turned your head, I saw that you were a man, because it looks like the future is female. So it's good to see you. Over to you for the next 5 to 10 minutes. Thank you.
I hope my screen is visible in presentation mode. Can you please confirm if you can see this in presentation mode?
Yes, Dr. Ian, you can go ahead. We can see your slide. We see two people walking on water. I think this looks it looks like Mars to me, though.
All right, good. Thank you for the confirmation. Yes, good morning, good afternoon, good evening, everyone. My name is Ian Tabsulwa, Project Officer by Biological Threat Reduction in our based in the Nairobi office. I'll be presenting to you our work through this project, the Fortifying Institutional Resilience Against Biological Threats project. And how I'll go about it, I'll talk about the signature initiative to get biological threats in Africa, through which, in support of which this project is being funded. And I'll introduce the project and also the activities that we are undertaking as part of this project. So the signature initiative is an initiative of a global partnership to mitigate biological threats in Africa and has 4 programmatic pillars that include biosafety and biosecurity, national governance structure, surveillance and epidemic intelligence, information. Through the project we implemented with MOA, we shall be addressing the first 3 programmatic pillars. This project has 3 objectives. The first is to improve our ability to anticipate, respond to, and recover from emergencies, ensure business continuity. Second is to strengthen our members' abilities and capacities.
Recording stopped.
Particularly in Africa. And lastly, to demonstrate our value and also the value of its services in country as partners of security organizations. So under this project, we have 4 work streams. The first will involve establishing an incident management system at our headquarters that keeps track of how we support members, this case being countries and territories, to respond to animal health emergencies. The second work stream, which is relevant to us in the room especially, is that we are implementing a number of capacity building activities in selected countries in Africa. Third, we shall be developing scientific and evidence-based guidance and standards for emergency management. And last, we shall have activities to disseminate practices for emergency management. So for this particular presentation, I'll focus on the second work stream that looks at activities in members in Africa. How we identified this is and put out a call for expression of interest, through which we identified 9 countries.
Recording in progress.
Positively. And then these 9 countries, as part of their response to the expression of interest, are required to identify which of these 4 areas they would like us to support in terms of capacity building. This includes disease intelligence, emergency management, sustainable laboratories, and health legislation. So after these are identified, we invited these countries to an reception workshop where they had a chance to interact with our staff that work on various programs relevant to threat reduction, and also our partner organizations that do the same work on the African continent. This kind of interaction, the countries were asked to develop national work plans, through which they indicated activities that they would like to support them with, but also indicated what partners they would like to work with as we implement these activities. The 9 beneficiary countries include Algeria, Congo Republic, Kenya, Madagascar, Malawi, Morocco, Libya, Tanzania, and Zimbabwe. And this photo shows participants at the inception workshop. Hopefully, may be able to recognize some of the partners here and also members representing countries. So from that, we were able to identify these activities that have been categorized into the 4 thematic pillars of the project. Under disease intelligence shall be supporting a number of countries with building capacity in surveillance. Under emergency management shall be having workshops on crime and terrorism. Shall be conducting regional training on how to organize and conduct disease simulation exercises. subsequently support some countries to conduct their own nationals. Should also be supporting countries to develop contingency plans for high-risk pathogens that are relevant for security. Under lab sustainability, we shall be having trainings on diagnostics for various related diseases, and also having capacity building workshops on biosecurity and biosafety. Shall have short-term expert exchanges where the existing countries are paired with a collaborating center or a reference lab over a period of time through to exchange expertise, and also to integrate activities to build capacity of the existing country. Shall also have human trainings on bioinformatics, data management, biological waste management. This has already happened, and shall also be having one-on-one communication. Under vet legislation, we had countries request for a vet legislation review through our program called as the vet legislation support program. And here our experts will be looking at the country's legal provisions for compliance with national frameworks that aid biological threat reduction. Thereafter, these reviews we shall support some countries to draft improvements of the legislation, regulations, and guidelines to cover biological threats. So far this year, we've had a training workshop for Tanzania on safety and biosecurity, animal health laboratories. We also had the same for Madagascar. In Madagascar, the country physically requested that we also have lab demonstrations. Which explain the second photo here. We also had a similar training for colleagues in Malawi, in Zimbabwe, and last week we had the regional training on biological waste management that was hosted by the National Institute for Communicable Diseases in South Africa. So in terms of upcoming activities that I may be interested in, we shall have national training workshops on biosafety and biosecurity, animal health labs in Morocco. This will be in Jan 2024, and for Algeria later in the year. We are also planning to host regional training on crisis, stroke risk communication, animal health emergencies, and shall also have the training for partners on how to conduct dissemination exercises. Shall have workshops on crime and terrorism in partnership with law enforcement agencies. And lastly, next year we intend to support countries that requested this activity through developing contingency plans for zoonotic diseases. This project is funded by Global Affairs Canada's Weapons Threat Reduction Program, and that concludes the presentation of the project. I would like to welcome if there are any questions or comments. Thank you.
All right, thank you very much, Dr. Ian Peter Busowa. Your name is quite powerful, and we want to say a big thank you. There are no questions as it is right now. Time is fast spent. Hopefully, we'll have you join us tomorrow again. Ladies and gentlemen, I know that you guys have been amazing. This is quite impressive. Please, can you put your hands together for yourselves? I like the encouragement you've encouraged me with. That I can assure you tomorrow we're going to have a much more, greater experience. On that note, the last abstract presentation brings to an end today's conference. Tomorrow we're going to have Madam Deborah, by God's grace, make her own presentation. I said we're going to be needing a slide for that. We'll ensure that the technical guys have their task well synced out. So this is about 6 o'clock, thereabout, as I promised you that I was going to be leaving here at this time, I believe. But we did quite well. So, ladies and gentlemen, tomorrow I would like to ask that we are here early enough so that we can have a full time. Because we didn't come at the time we were all expected to be here was the reason why we didn't kick off the time we should. And the opening ceremony starts at 9 on the dot. So please, let's pass the word across. They'll be here quite early. My name is Stephen Lawson. It's been a wonderful day one with you all at the 9th African Conference on One Health and Biosecurity. By the grace of God, we will see you tomorrow. Please go home safely or rest well till tomorrow. God bless you. The conference is hereby closed. Bye-bye.